Amit, you can also join. We'll try to show some cases in regards to multiligament knee injury so that we can put out some discussion and come out with some salient points which will be helpful for everyone. So let me show the first case. A lady of about mid-30s who has come with a polytrauma, has head injury, had a tibia fracture, acetabulum fracture on the same side, and she was referred to me after about 3 weeks from the time of injury for ligament surgery. Okay. This was the original X-ray of her, and she presented 3 weeks ago in another hospital. She presented with this fracture and also acetabulum fracture, along with a minor head injury. Head injury was treated non-operatively. So, what would you do for this? Amit, you can answer.
I'll send to trauma surgeon first. Because I don't do nowadays, but it's probably...
So, obviously it's a trauma case, okay? Yeah. So, you'll go for a fixation.
Of course.
Fracture fixation is the first priority of choice. So, I think everybody will agree for that. So, accordingly, the surgeon who referred me, he went for the fixation. And after fixation, in the post-op X-ray, he found out like this. Okay. So, he did a fixation for the tibial shaft and also for the proximal tibia. He managed to put a tibial plate posteriorly. And he didn't realize that knee was malaligned at that time. But after post-op X-ray, he found it, and then only he referred to me, sir, he said ligaments all completely ruptured. So, I am sending you for a ligament surgery. So, what do you want to do now? It's about 3 to 4 weeks from the time of injury now.
You see, there is a subluxation of the knee joint, which is not to my liking, you know. The joint is out of the track. So, in 3 weeks' time...
You're just going to change the slide now, okay, 1 minute. You just change the... Okay, you carry on.
In 3 weeks' time, I don't know what to do with the subluxation, but I'll still try that if it is closely reducible or not. So, my first, choice will be to reduce the joint first. And then probably if it is a multiligament and then so many surgery has been done, I'll put on external fixator for some time and then he'll decide what to do.
So,
now this case, once you have got so many implants there, you can't get a good quality MRI anymore. So I think a good way to progress from here is to start doing stress X-rays. So you do a valgus stress X-ray, you do a varus stress X-ray, posterior stress X-ray, and see actually...
Okay, so you are saying that you make a clinical assessment.
Clinical assessment and radiological assessment based
if clinically not possible, you do a EUA, that's what you are telling, is it?
Yeah.
EUA means you have to give anesthesia.
And then you start to, the second step would be to do a diagnostic arthroscopy, see what's happening inside the joint. Okay. So your diagnosis and the next plan depends on these two things, an EUA and a diagnostic scopy.
Ansu?
I think there's a medial sided injury from that AP X-ray that I could see. I could also see that probably there is a PCL injury because there's a the eminence where just above the champagne, looks like a PCL avulsion there. That's a mal-rotated X-ray. I don't know. I'm not sure. We actually need proper knee X-rays. This is a leg X-ray.
Okay. Yeah. So he rightly suspected all this and he went for MRI scan. And MRI, obviously, as Amit and Manu suggested, it's very difficult to read because of a lot of artifacts from the metalwork that we have there. Okay. They did metal subtraction sequence, and then at the end, the final report is like this. Complete avulsion of PCL, as Ansu correctly suggested. ACL is also ruptured, and MCL, FCL doubt is also there. So, what is the plan of management? Naresh, you tell me. What do you want to do? Now, we tried clinical assessment, as Mano was suggesting, and the movement that we can get is only from 20 to 60 degree. Doesn't move any further than that. Varus valgus, she is having pain, but not much unstable, okay, because you cannot do much varus valgus and all. But knee is subluxed for sure, as you can see from the X-ray.
Yes, sir.
And she is having pain also.
A good way from here is would be to go with what Amit said. Reduce the joint. Get your MCL in place. If you want to reconstruct the MCL, get your MCL in place. Reduce the joint and put it in X fix. Because you can't do ACL, PCL with so many screws there.
Correct.
So you have to wait for
Gopi,
some time to remove
I
that.
think I need your opinion. What do you want to say?
So in this case, anyway, you know that it is a multiligament injury. First and foremost is to get the alignment. Alignment correct by close reduction if you get, it is well and good. If you cannot, you do the open reduction. And then get the correct tibiofemoral space on both sides. Put an external fixation in the midline. Here patella also seems dislocated, but we don't know about the other x-rays. Mostly it is also dislocated. Now for 4 to 6 weeks, you have to keep it like that. At 4 to 6 weeks, you remove the external fixator, start mobilizing. If you get some movement, then it's good. If you don't get, at that time you can go for an arthrolysis, arthroscopic arthrolysis. You get some movement. And then at 6 weeks, you can go for a PCL reconstruction and MCL or LCL, whatever
So
it is.
when
ACL,
would you
the
do
last-
all those? Would you do all in the same
When you
sitting?
get some range of at least 90-degree motion should be there before you attempt any of the ligament reconstruction. So if it is stiff in extension at 6 weeks,
So your suggestion is you do as a two-stage procedure. Is that right? First stage you do the reduction of the joint, and then
two
leave it
stage
as
minimum 2 stages. Third stage is for ACL. If it is needed, you can do. ACL will anyway omit. So 2 stage minimum.
Sir, if I may add, I would, that's a bony avulsion of the PCL. So fixing that bony avulsion would correct the sagittal plane issue that we're facing. And that is the most critical. So I would definitely fix that early, because the patient is anyways being taken up for surgery. I would do a medial sided repair of whatever is possible, augment with a graft. So that would sort out my PMC and PCL. And later we'll see, because he'll end up with some stiffness, probably will never need an ACL.
When you do open reduction of the knee, as I told, at that time you can fix the Avels fractures
So we went
or in the
in
meniscus.
because we went in, gave anesthesia, we tried to reduce it, it won't reduce. Okay. Obviously we expected it won't reduce because it's about 3 to 4 weeks down the line, it may not reduce at all. And we opened it, and we found out medial structure, medial femoral cord is almost like very close to the skin. So which means there's some soft tissue was in between the joint. That's why it's not reducing, which is expected. Okay. So we after releasing all those tissues, we got it reduced. Then we put an external fixator. And how long later after external fixator would you do surgery? That's the question. 4 weeks. So-
I keep external fixator for at least 6 weeks. Then I remove, try to achieve some range of motion after physiotherapy, maybe another 2 weeks of rehab, and then only I take them.
So I think the first point for this case I want to pass on is this patient was referred to me for ligament surgery, and the patient came and asked me ligament surgery to be done on the next day itself. The first point is, when somebody has fracture, we all think there won't be any ligament injury at all. There can be ligament injury with fracture, and you cannot do any ligament surgery when there is no mobility. At least you should have, I think Gopi was saying 190 degrees. I think even better, even more is better. 110 degree, 120 degree movement has to be there before you considering any ligament surgery at all. That is a first point to be taken home for this particular case. Okay. So that's what we did. Okay. After 4 weeks we did ACL and PCL avulsion. That's all. Otherwise all ligaments are stable. The patient was absolutely fine after. So after 6 weeks we did removal of X weeks and same manipulation at the same time, assess stability at the same time, see how stable it is. We assess it is ACL and PCL was gone. From there we left 3 weeks time, and then we did ACL PCL surgery. So that is the message from this case. So this patient has got a
If you don't get 120 degree on day 1 or at 4 6 weeks, it is straight fixed. You get only 10 degree. What will you do? You got only 10 degree at 6 weeks or 4 weeks. When you remove the external fixator, you got only 10 degree movement.
Then you have to do manipulation. Manipulation and try to get movements back.
Manipulation.
I had one patient like what you are saying who was referred to me because he had external fixator removal and there is no movement. I went into arthroscopic adhesiolisis fully and got the full movement back up to 130 degree movement, and then send the patient home with CPM for a few days, and then send the patient home, get rehabilitated for about 4 to 5 weeks so that his movements are completely back, and then you do the surgery.
Sometimes you do an arthroscopic arthrolysis.
Arthroscopic adhesiolisis, yeah. Okay. So now this patient was 40 to 45-year-old with a knee injury. Okay, she presents to me in about 4 days time like this, 4 to 5 days time. So, Naresh, what's your diagnosis?
Sir, there is a fracture of the fibular head along with the lateral tibial condyle.
So there is a lateral complex LCL avulsion fracture is there, so otherwise called as arcuate fracture. For the, I think arcuate fracture is a terminology that is used for this condition. And there is one more finding. What is that?
Lateral. Yes.
Mano, you tell. Yes. So another fragment that you are seeing over there is a ALL avulsion fracture. So it's a Segon fracture which is displaced. Commonly we see this in ACL cases where it's an undisplaced avulsion fracture. Here is a displaced avulsion fracture of the anterolateral ligament. So invariably patient is going to have a ACL injury also. ACL plus ALL plus LCL avulsion. So about 5 days time she has come. When would you, what will be your management plan and when would you do that? Will you do it immediately or will you wait for some time and do it, or what will be your plan of action?
First I would
just
like to-
timing of surgery? Timing of surgery you asking? When do you want to operate or something like that?
Yeah, when do you want to operate? Or do you want to operate or not first?
Yeah.
You need to operate. So everybody agrees that.
100%, yeah.
He needs surgical
Sir,
treatment
first,
only.
like-
So when do you want to do surgery and what do you want to do?
would like to get MRI first to see.
MRI, okay. The MRI is shown. MRI is showing, confirming the ACL tear, as you can see over there. And we know there is LCL avulsion is there, and ALL avulsion is also there. We found out LCL fibula head fragment is comminuted. So it is not in one piece, 2 or 3 pieces are there. And ALL fragment is also there, which is in a small piece, about a half centimeter fragment is there. This is what there is a CT scan picture also. I think I showed that CT scan picture is also there. Okay. So what do you want to do and when do you want to do?
Do an ACL, do a fibular head arcuate fracture fixation, double it up, augment it with a maybe semi-tendinosus graft in a Arcero pattern. I'm not very sure about the PLC. PLC looks healthy, so probably I'll just get away with a LCL fixation and augment with a ACL fixation. At 45 years, I'm not interested in doing an ALL.
Amit? You have to answer me when to do surgery also. So because the patient had injury about 4 days ago only, she is having swelling, pain and difficulty in moving the knee also. So when do you want to do the surgery and what do you want to do?
If everything permits, I want to do it as soon as possible because there are small fragments. I need to identify the crater properly and the crater hasn't healed. So it should be within 2 weeks I'll plan for surgery. I'll do ACL reconstruction. I'll fix the fibular head probably with the anchor or TBW kind of device using there. And using an anchor, I'll definitely fix the ALL bony fragment as well. I'll see because it's the same area where I'm exposing. I'll go little anteriorly and identify that the fragment, ALL fragment, and if it is fixable, I'll use anchor to fix it back to the same position.
Okay.
It depends on a given situation. If the swelling is so huge and painful and the knee is so angry, I will just fix the avulsion fragment first. I will leave everything for the second stage. Now when the knee becomes less angry, I will go for ACL reconstruction. ALL fragment can be fixed or any tenodesis on the lateral side if it is done delayed.
Single
So first-
stage or 2 stage?
First fixation is single stage. First stage is single fixation. Only fibular avulsion fragment. If the knee is swollen and angry, only one surgery, that is fixation of the avulsion fragment. When the knee becomes less angry, means less swelling, less pain, then I go for ACL reconstruction and anterolateral reconstruction.
I think there is no right or wrong answer for these things. Okay, yeah. The intention is to get the movement back fully. If you go and do sooner, sometimes you can get very bad stiffness also, which will take long time to recover. So people prefer to 2 stage also. Some of them do single stage with aggressive rehabilitation also. So optimal time for surgery is not immediately until you get the movement back. That's why we put the CPM on and get at least 110 degree movement. If you are going to get it in about 3 days time or 4 days time or 10 days time, it may be the time you do the surgery. So I did the surgery in about 12 days time. And then what we did is, sir, you were asking some question. What do you? Speak in the mic, please. Come and speak in the mic. Common peroneal is normal. There's no palsy there. Okay, thank you. Yeah. So what he's highlighting is there's about 30% incidence. Common peroneal can have palsy. So, but this patient is lucky, did not have any palsy. Okay, yeah. So what we did is we opted for a screw anchor fixation, where we fixed LCL avulsion with like a standard double row repair that we do for cuff repair. So put one anchor on the fracture site itself and take multiple bites through the LCL and a knotless anchor on the fibular metaphysis. And for ALL we did a suture anchor fixation. So both have been suggested to be equally good. If you have big fragment, then you can go for a screw fixation and tension band wiring. But this fragment is a too small fragment or a comminuted fragment, so holding any screw is not going to be that easy. So we went for this kind of fixation, where we did. It's a good thing we have to isolate common peroneal always when you are approaching the lateral side, because if it gets damaged, then it can be a permanent problem for the patient. So do supine neurolysis. FCL avulsion is fixed with anchors and fibula head, knotless anchor, ALL repair is suture anchor. Only problem with this is rehabilitation. This is a post-op X-ray in 4 weeks time. This patient, in spite of we doing CPM for 4 days, 5 days and getting 100 degree movement, this patient took me about 3 months to get good range of movement. 3 to 4 months. Because rehabilitation is always a challenging for these patients because stiffness is a big issue.
Sir,
Yes.
so why not, is it then probably a better option to stage this? Just do the fracture at stage 1 and then once the knee settles, and if she has complaints of instability, do an ACL in a 45-year-old
Yes,
homemaker.
that's exactly, absolutely acceptable. That's what I am saying. There is no right or wrong answer. We can in fact do as extra articular structures first and do the fixation and get the rehabilitation sorted out. Sometimes these kind of patients may not come for ACL surgery, but ACL can be posted for about 3 months or 4 months later. That is a perfectly good option also. So this patient took little longer time for me to rehabilitation, but they wanted one surgery, they were not ready to accept these things, so we went for single surgery. It went smoothly, no issues, but rehab was a little challenging, it took 3 months. So the second option is you have to think about doing 2 stage. 2 stage means 2 anesthesia for the patient, 2 times surgery, 2 times rehabilitation, all are there. So
Do you need to, can you get away only with that kind of a suture anchor repair in this kind of arcuate fractures, or you want to augment it with some Larsen kind of a protection?
additional in terms of graft. That is a good question. In case of avulsion fractures, where you have good soft tissues retained over there, you can very well just get away with a repair. You don't need to do augmentation at all. If it is a missed substance tear, then I would definitely go for a repair as well as augmentation also together. That will be my choice.
Is the delay or the sluggish rehab process because of the fact that you are trying to protect your lateral?
No, my practice is not like that. I do repair for avulsion fractures. That is more than enough. Augmentation doesn't anyway progress to rehabilitation. Rehabilitation will be same for that also. Okay. What is the opinion of other panel members?
Yes.
Would you augment in these cases or you just do repair?
No, in this case there is no need of augmentation or reconstruction. Just repair sort of treatment is enough. But it is chronic, you have to do. My doubt is your rehabilitation same in PMC or PLC injury, or is it different? PMC injury and PLC injury, rehab is same or different?
Same.
There is some difference.
So I think my take is, for this kind of a fracture, I would not put any anchors. Reason being, the medial row anchors, even in the shoulder, they rely a lot on the bone that is there. Here you're putting it in very soft mushy bone. the lateral anchors, when you go down in the fibula, it is very hard bone. Sometimes it is very difficult to put. Even if you are successful in putting, there is always a fear that you might, split the fibula. So maybe doing a transosseous repair, just like in the cuff, we know transosseous repair beats everything.
A very good point what he is telling. Actually, these fibular anchors diameters are big. It may not go into the cortical bone very easily. So you have to have a drill. We drilled it. 3.5 mm drill you have to drill. Just with the owl it will not go. I think good point noted. Okay. You have to have the 3.5 mm drill for this anchor to go. And you have smaller diameter anchor available. 4.5 mm anchor is available. So we use that one for this case. So this one will be a good case. This is a patient, 26-year-old, presenting in 4 weeks time with a multiligament injury. This is the UVA finding for him, where varus valgus both are unstable. Okay. Anterior drawer is positive, posterior drawer is positive, and the dial test is also positive. So he has got ACL, PCL, MCL, LCL, and PLC. All the 5 are there. Okay, it's just for quickly run through for everyone. What will be your plan? Single stage or 2 stage?
X-rays, MRI.
Huh?
X-rays, MRI. X-ray.
X-ray is normal, nothing wrong with
MRI.
X-ray. That's why I did not put. MRI also showing these ACL. I mean, more than MRI and all, I rely on the UVA findings in these cases. UVA gives much more. MRI will tell a lot of things, partial tear and all.
But we want to rule out avulsion fragments first.
5 minutes, okay, we'll finish this.
There is an avulsion fragment.
There is no avulsion fragment. These are all only soft tissue injuries only. Single stage, 2 stage.
Meniscus, we want to know about meniscus.
Meniscus, I don't think this patient had any meniscus tear.
So normal meniscus.
No meniscus tear, only 5 ligaments.
So here the importance is given for the clinical assessment. Here the virus stress test as well as the dial test is positive. That means you have to give importance for the PLC. PLC has to be given importance. You have to reconstruct PLC, then the collaterals, the medial ligament, and then the PCL. And ACL you may repair or not, you can decide later on. So all the 3 together, ACL the last.
So how many of you will go single stage, how many will go 2 stage?
2 stage.
2 stage. Single. Okay. So in 4 weeks time, when the patient's knee is quiet without any swelling, we can go either way. Okay. But if it is a swollen knee where still acute features are there, better to go for a 2 stage only. This one either you can go either single stage or 2 stage, because the knee has got full range of movement available. Not in UVA, in clinical also you had full range of movement and quiet knee. So you can still think about going for a single stage as Amit was suggesting, or you can go for a 2 stage. But in a swollen knee, you go for a single stage only, 2 stage only. Okay, that is the point. So graft, which one you want to use? For 5 ligaments, what are the graft choice? Tell quickly for the audience sake.
So if I am to do it this, peroneus longus for the peroneus longus and ipsilateral gracilis combined for the PCL. I will use ipsilateral semi-T Lind technique Zoshi
take
modification for the MCL.
Ipsilateral ligament for when there is MCL injury, ipsilateral hamstring.
Yes, I will. I will
Okay.
use the semi-T for the PMC. I will use
Okay.
the gracilis to augment my PL. And I will use the contralateral semi-T to do a RCRO kind of a PLC. 2 stage.
Any other
Second
difference
stage.
in management from any of you?
For poplitis, what will you do?
No, I would do an RCRO kind of reconstruction, sir. Single tendon.
It's a tibial based.
Yes, fibula based.
Fibula based only, not tibial based.
So what I used is, I did not use the same side hamstring. Apart from that, I took 2 peroneus, opposite hamstring and central quadriceps. The opposite hamstring, we took gracilis for LCL and semitendinous for PLC. So opposite hamstring is used for PLC and LCL. Peroneus is used for MCL. One peroneus is used for PCL. CQT for ACL. That was I used for this case. Okay. Sequence of fixation. Tell me. This for them only. You tell. How do you fix it? So you got all the ligaments there. Which one you want to do first? Which one you want to fix?
First PCL.
So PCL is a central core ligament which gives the stability for the knee joint. So it has to be fixed to keep it in the center. Next.
So first I'll do PCL. I'll probably not do the ACL in this case. Then I'll go to the lateral side, do the PLC and the LCL. Then come medially and do the MCL and PMC.
Anybody any disagreement with him?
So if I'm doing all, so my first I'll start with PCL, then PLC, then ACL, and finally MCL.
LCL?
Finally, last MCL.
So first is PCL you have to fix, and then you have to fix the LCL and the PLC, and then you come for ACL. Last you do the MCL and POL if there is there. This patient did not have POL, so only MCL. Okay. This is the sequence of fixation on this. Okay. So tensioning sequence cell. How would you tension it? Which? Mic. Give the mic to him.
Had there been such 4 ligaments, 2 cruciates, 2 collaterals, what's wrong if you do the collaterals first and cruciates in the second stage, maybe after 4 to 6 weeks? Because for collaterals, you need to immobilize them. You don't mobilize them very early, whereas cruciates, we mobilize them early. And if you are lucky, on the medial side, it could be a femoral avulsion or something where you can get away by repairing the MCL, dual LCL posterolateral reconstruction. After 4 to 6 weeks, come back and do both cruciates. That is also a possibility.
Fine. So positioning of fixation. Please tell it for the audience sake. In what position you will fix PCL, and then what position LCL, PLC, MCL, and ACL.
I start with the femoral PCL, then tibial PCL, both
At
of
what
that
position?
in 90 degrees. Then PLC in 45 to 50 degree, LCL in 30 to 45 degrees.
No. What degree? 35 to 40 degree in valgus, varus, rotation, which way? You have to tell all those.
Okay. PLC in neutral, LCL in valgus, PCL with anterior drawer.
So everybody clear about what he is saying.
MCL and POL in varus, neutral rotation.
MCL will be done. Any other changes, please? I think he has to complete a little more. That's why.
So I'll do PCL fixation single bundle at 90 degrees with the drawer force. Then for the PLC, because I'm doing an RCRO kind of a reconstruction, my lateral collateral will be at 30 degrees, no rotation, no closing because the medial side is also lax.
Okay.
The popliteus will be at about 60-70 degrees, no rotation, no closing force.
Neutral rotation.
Neutral
Yeah.
rotation,
Yeah.
yes. On the medial side, the MCL will be at 30 degrees. Again, no opening closing force, no rotation. That is neutral rotation. And the POL, if required, will be in full extension. Again, neutral rotation.
POL will be done in full extension.
Yes.
Yes. And ACL will be like 20 degree flexion.
10-20
So that is a typical sequence everybody has to follow. Okay. Yeah. Oh, that is I think is that time?